afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Most of you are familiar with our risk management consultation service, the Advocate 800 program. It's one of our many benefits that our policyholders receive through the Trust. Three of our advocates are with us today, Drs. Daniel Taub, Julie Jacobs, and Liesl Bryant. In the interest of time, we've placed their bios on a slide. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other Trust risk management credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Great. Thank you, Jana. And we are thrilled to be back with all of you. As usual, we have several questions that have come in between the webinars. So we're going to start with those first. And then thanks for those of you already entering your Q&A, your questions in the Q&A. We will get to those right away after this. So just to jump in for time's sake, our first question, and Julie, I'll direct this to you first. It says, I am considering not renewing the lease for my office building and moving permanently to a telehealth only practice out of my home. What risk management issues should I be considering?
A great question, and I think that it's not an uncommon scenario that we're hearing lately, is that folks are sort of recognizing that they're going to be sticking with telehealth for the foreseeable future, and it makes sense to get rid of an office lease and start working from home. So I think there's a number of different things you want to consider in different categories of considerations when you are thinking about that move. First being clinical considerations. You have to think about the nature of your practice, the types of clients that you see, types of interventions that you engage in, and make sure that those are appropriate for a telehealth only kind of format. You're going to be less flexible if you're working with telehealth only. You won't really have the ability to switch gears in the middle of therapy and go back to in-person services. And so you want to make sure that it's really a good fit for the kind of population that you work with and the kind of interventions that you generally engage in. You also have to think about whether you do any type of assessment or evaluation and whether those are going to be things that you can do effectively in a telehealth only kind of environment. I also think we need to think about our own sort of provider considerations too, and think about whether you have a situation where you can maintain adequate privacy and confidentiality with a telehealth only kind of situation. You know, how many people are in the home? How easy is it for you to get into a quiet space and where you can feel that you're able to provide these services in a confidential way? Will you be able to maintain a good work-life balance if all of your work is in the home? I think we've all sort of learned that lesson recently, having been forced to work from home either for a long period of time or even short period of time. What is that like? Is that something that you're able to maintain? Are you able to maintain good boundaries? You know, you have to be able to turn it off at some point. And so if work is home and home is work, how can you make sure that you can really do that in a healthy way so that you remain emotionally competent to do the work that we need to do? You don't want to get burnt out. It can be pretty isolating. You know, there's a lot of benefit in those curbside consultations that we can engage in with colleagues who are in an office setting. So you want to make sure that you've got some other mechanism to not become too isolated. You know, maybe setting up remote peer consultation groups on a regular basis, things of that nature, so that you can make sure that you're taking care of yourself and that you're not getting overly isolated. You also have to think about considerations related to any requirements, legal requirements in your area. Some states, some jurisdictions may require that you have an initial session face-to-face before you engage in telehealth services, or may require that you have periodic face-to-face check-ins when you're doing telehealth services. Now, some of those requirements have probably been waived at the current time because of this crisis, but these waivers are going to expire. So you have to make sure that if you are going to operate a telehealth only practice, that that's actually legal and permitted in your state and your jurisdiction. Will there be any insurance reimbursement issues? It doesn't seem like there should be. Telehealth is telehealth, but you would certainly want to check with any insurance panels that you're on and make sure that it's acceptable to only have a home office and that you're not required to have some kind of separate office space as an establishment of that insurance contract, insurance relationship. Similarly, with your liability insurance company, the trust does not have any problem with you operating a telehealth only practice, but we can't speak for all malpractice insurers. So make sure that your liability insurance isn't affected by that. And obviously you need to notify if you do have an address change. You'll have to notify your liability insurance, your licensing board, probably the insurance companies as well. Along with that notification goes with the sort of practical consideration of, do you want to give your home address out to all of these different entities? Do you want the insurance company to be posting your home address online when they're posting their list of providers? So you need to think about some other options. It may be possible to establish a PO box as your mailing address, but you need to make sure that that's acceptable as an office address with a board or with an insurance company. And if not, you may need to make some kind of alternative arrangements. Sometimes licensing boards post the practice location online. A Secretary of State may post the address of the registered agent online. And if those are your home address, a savvy client could very easily find out where your home is, and that may not be something that feels comfortable or safe for you. You also want to think about those situations where telehealth is not enough and you need to have a face-to-face appointment with someone. If there's crisis management or something along those lines, it might be a good idea to set up a backup plan. So maybe there's a colleague who has an office, or there's some appropriate office space that you would be able to use in one of those situations where telehealth isn't enough and you really need to do some kind of crisis management or in-person session. And then there are tax considerations. If you have a home office, you'd want to talk to your CPA about how that might impact your taxes. And then finally, cyber liability coverage. And that's not just for this question. I think that's something that we should all think about if we're moving into a more technologically based practice. Cyber liability coverage is a really good idea. So that would be something to consider and look into. And that's a lot, and there's probably more. So if Dan or Lisa, if you have any other ideas, I think that's a good start, but welcome to hear your thoughts on that as well.
Well, I think we covered a lot, Julie. Dan, do you want to add something?
Actually, I just wanted to highlight a couple of things, Julie, that you said that I think are really, useful to consider. And this is doable, by the way. And I know that more and more people are going to move toward doing home office. But one of the considerations about that you mentioned, and just to again bring a highlighter to this, Julie, is your addresses and it being not only the board publishing it, but also whether they'll accept it. If it's a PO box. Yeah. So sometimes we have to live with that tension of giving out information that a patient or client may find more easily, because now it's pretty easy to find one's home address regardless. But that being said, if you've been pretty good at keeping it from being found, having it on the licensing board site, if they require the actual physical address, is an issue. And then the other part that you raised, just again, kind of a highlight is that when you start claiming your home office on your taxes, you got to talk to your accountant and a tax attorney about what happens if you sell your house and whether you can include that chunk that was your home office in the kind of usual deduction you do for a resident. So there are just some detail related issues, Julie, that you're referring to that aren't prohibitive in my view, but it requires attention.
Yeah. No, I agree. And I know you mentioned this too, but I think just to underscore a different point is the clinical piece, right? Because for some folks, if you move to telehealth only, you'll be sort of, you might change the population of people that are willing to come see you. So it is something to be really mindful of. But as Dan said, doable and maybe right for some of us in some situations. So, okay, question number 2. And Dan, I'll let you start on this one. I am seeing some clients in person in my office. If someone gets sick and I am contacted by the health department for contact tracing, do I share the confidential info on my clients? Is it something I need to put in my informed consent documents?
Okay. This has, as you know, Lisa, this has been coming up in our calls of late because we've been having callers and psychologists who have had contacts by Department of Public Health. And this is going to be largely determined by state law. HIPAA does allow disclosures to departments of public health for infectious disease purposes. However, not all, in fact, most states aren't very clear about that. And if the state's law is more restrictive about confidentiality. That is, it's a higher standard of privacy for and gives more rights to clients and patients than the state law applies. So it's a bit more complex than simply, oh great, HIPAA says it's okay. One has to be really careful, because if your state doesn't allow that, the higher level applies, and then one would not automatically be able to disclose the information, which can create some tension. Lisa, if the Department of Public Health, my local county Department of Public Health, gets in touch with me and they demand information about who was in my office, one of the first steps I can take is to request a copy of the specific state public health law section that creates an exception to my confidentiality rules. Now, I live in California, and there is an exception in the California Confidentiality of Medical Information Act that is aligned completely with HIPAA. But in many states, that's not the case. And in some circumstances, our colleagues have been hearing from local departments, oh, well, take a look at the department, or rather the public health law. Well, in many places, that's hundreds, if not thousands of pages long. That's not sufficient. So what one may need to do, kind of as a second step, is to consult with local counsel about whether it is permissible under state law. But third, perhaps a simpler and maybe less expensive solution was embedded in your question, Liesl, and that is you can ask for patients to sign an authorization to disclose information to the Department of Public Health if they want to be seen in person. It can be part of the reconsent process for a person to come back into in-person care. Please note, though, that we have in our sample informed consent form for returning to in-person care a specific section on the fact that the public health department may contact the clinician. Informed consent is important, but we're also suggesting that you get a separate written authorization and describe what information the local DPH may require for us to provide. So it could be the patient's home address, their email, their phone number. That, by the way, is pretty easy to find out from local Department of Public Health. And you can also be in touch with them and find out if, in fact, they have any rules that will or laws that will trump the usual confidentiality standards for a mental health professional in your community. So being familiar with your local process beforehand can help reduce the surprises here. It's also important to tell our patients and clients in that context of doing an authorization what can happen. So for example, they may be contacted by DPH and we may only give limited information, but the patients themselves can be asked for a list of their own contacts, the workplaces they've gone to, any other public places they've been, okay? Now the fourth aspect of this is that regardless of whether the law permits it, like HIPAA in California, or one gets permission, it's important to try to stay with the minimum necessary information. The person's name, their contact information, and that can leave at least somewhat ambiguous the nature of the relationship. If I've come into your office, Liesl, and I'm a patient, and you have to give out my name and my address and phone number and email address, you don't have to say I'm a patient. I could have been the plumber who came in to fix your sink in your office, or another office person sharing your office, or a staff person. Now, a related issue, although not exactly the same, and I'll try to finish on this note, not take it too long, is that if you learn as a provider that your patient, somebody you saw in person, has subsequently tested positive for COVID-19, but you haven't been contacted by the public health department, there's now not a legal mandate, but there is, I think, an ethical responsibility here. And it's also good risk management. You, as a therapist or assessor, can, and I believe should, notify all patients who may have subsequently been exposed, but you do not have to disclose any identifying information about the person who was tested positive. For example, I could say to my patients who I've seen since Monday, I was notified that a person who was in our offices on Monday tested positive for COVID. Please contact your physician to get direction about whether you should be quarantined, tested, and so forth. So those are some considerations around contact tracing.
That's great. Julie, anything you want to add there?
I just want to echo and emphasize, I think if it's possible to be proactive and get some of this information ahead of time, it would really be helpful, I think, for the providers to not have to scramble at the moment that they're being outreach to. So if you can find out a little bit more about what would be required to be reported so that you can include that in your informed consent and in the ROI. And I do like that belt and suspenders approach of having it in both the informed consent, but also being really explicit and having that release of information. I think risk management wise, that makes a lot of sense and gives us some more protection.
Yeah, I agree with you, Julie. I think so much of this is really about, like you say, knowing the law. And by the way, one place, if you don't know it or can't find it, you could potentially check with your state association. They may be able to know it, or they may have a committee that in fact would find out and then notify their members. So that's one resource we can use. And then a lot of it really comes down to informed consent, right? One of the big risk management trifectas, right, of the three. So that's really important, as we always do in these situations. Okay, third question, and Julie, will come back to you on this one. I have been considering options for doing in-person therapy in outdoor locations, such as parks, walking in neighborhoods, or even meeting in the client's backyard. Is this okay to do? And what are some of the risk management issues I should be considering? We've been getting—
Great question.
In fact, there's even some in the Q&A, so.
Yep. We are getting this one a lot, I think. And, it's partly because it's summer and it's nice out and we actually have the option, whereas in March, it was not necessarily quite as appealing. And I also think it's partly informed by, at this point, it seems like prolonged exposure indoors is really the highest risk right now, or is a really high risk for exposure. So, if you don't have a window where there's an opening, window you can open, an office with windows or HVAC that you can control, and you do have some sort of area outside, this might be a really good way to meet folks' needs. But there's a lot of things you need to think about, and you have to kind of go down the risk management worst case scenario roads sometimes and think about all of the things that could happen. And I think you want to look at things that can be related to safety, privacy, and clinical issues. And so safety kinds of issues, and this is really, it seems like it's stating the obvious, but you're going to be outside. And so there's going to be the potential for exposure to the elements. There's potential for tripping and falling, things that aren't really considerations when we're sitting in our enclosed, safe offices. So you want to think about, those types of things. And like with most things, informed consent that's related directly to this would be a good idea. It would be a good idea to create an informed consent document. Doesn't have to be complicated, but just outlining some of these risks and unusual things that could happen. So the potential for some sort of exposure to elements or injury, confidentiality issues are huge, right? I mean, you're outside. So not only is there the potential for other people, strangers, to overhear what you're doing and overhear your conversation, but certainly people who are known to you or your client could happen by and want to say hi and have a chat with you. So you want to think about what you're going to do in those scenarios and be really explicit. Talk to your client or patient about what would we do if someone who walks up to you. I mean, I think generally the clinician will follow the patient's lead in that situation. And then similarly, you need to think about what you'll do if someone walks up to you and says howdy. Excuse me. So be really explicit about that and have that conversation and document it beforehand. You also want to think about whether the client is appropriate to be taken outside for walk and talk therapy, or the topic of the therapy, right? So if you're processing complex trauma, maybe not the best place to do it outside in a public place. Now, if you have a private courtyard somewhere where there's not going to be people around, it's certainly going to depend on what kind of situation you're talking about. If you're lucky enough to have a really private environment that's outdoors, then some of these things are not going to be as concerning. But you do need to think about whether the topic and the type of work you're doing is appropriate. Do you have folks with serious suicidal ideation and impulse control problems? Do you really want to be outside with them versus in a more contained environment inside your office? And then just sort of, again, more along that same clinical line is to think about the fact that this is potentially a more casual type of interaction, right? We're hanging out in the park with our therapist, or we're taking a walk with them. So does that have the potential for blurring the boundaries a little bit and making it less clear? And we talk about boundary crossings and boundary violations, and if it's one thing and you're very clear on boundaries otherwise, then may not be an issue. But you want to make sure you're not building towards the client feeling like there's a more intimate or more casual interaction or relationship going on. Your clients may feel less secure, they may feel more exposed, they may really like the confines of the office, and that may be a safe place for them. So you want to think about the impact on the clients. in those confidentiality issues and privacy and safety issues. And informed consent, again, create a form. We actually don't have a sample for that, although we seem to have a sample for everything else. So that would be something that I think you could, I don't think it needs to be complex. I think it really just needs to address those obvious things that might come up. And, you know, anytime we're doing something that's a little bit of a deviation from our normal practice, we want to document why and engage in some kind of consent process. So I think this is not much more different than that in those considerations.
Yeah, no, I agree, Julie. Dan, any additions?
Yeah, I mean, the great points, Julie, about, you know, informed consent, and that, but I want to remind the folks watching us today that in some ways, doing treatment out of an office is a time-honored approach. When you do exposure for agoraphobia, for example, there are many of us for many years. I know back in the Jurassic period when I was an intern, I was doing that a long time ago. And so it's not that it's so far out of what a psychologist or a psychotherapist can do, but rather the preparation for it and looking out for around what are the risks and how do we prepare people. So I see it as being potentially very legitimate. The other thing that I like, Julia, is that you were emphasizing the particular client's or patient's needs and their presentation and their risk levels, because the reason for doing, for example, in vivo exposure with agoraphobia is that it was a more effective treatment. The reason for seeing people outside right now has to do, among other things, with the fact that in-person work is really a challenge. And I think we have to be careful not to assume that walking side by side means that all of the other aspects of trying to protect against the transmission of COVID-19 can be put aside. And so, you know, we need to weigh those risks, but it's by no means, again, prohibitive. This is an area that we've been doing and practicing in this way in certain types of services for many, many years.
Yeah, I agree, Dan. I think you made some really good points. And one of them, to get to like the precautions with COVID, right? Just because we're outside, we may still wear a mask. We may still need to maintain that 6 feet distance, right? It's not that, oh, then we cannot have a mask on or then we're going to be super close. That may impact the confidentiality, right? If we're in masks 6 feet apart from each other, we're going to be talking more loudly. I agree, there's just many more things to think about. And, you know, one of the things I think it's important to remember is there's no black and white here. It's not like, yes, do it or no, don't. This is complex. And like Dan said, you want to think through what are the risk factors, and it's very case specific, right? So I really think, and I assume Dan and Julie would agree with me, but that you really want to be making these case by case decisions, not just all my patients outside, or I'm not going to meet anyone outside, right? Okay. And our last question before we move to the live questions, Dan, and I'll start with you on this one. Can you speak to the differences in providing supervision of graduate students via telehealth, and if there are any specific risk management factors we should be considering?
Okay. So for those of us who do training and supervision, and many of you do, this has been, you know, the question of the hour with COVID. And in terms of pragmatic risk management issues, remote supervision really carries with it very similar and very addressable challenges to doing remote care for patients. It has to be secure. We still advise using a HIPAA-compliant platform, despite the fact that the Department of Health and Human Services has loosened its enforcement of COVID, of those types of standards during COVID-19. And then just this past Monday, they extended it another 90 days. So, you know, that has been extended, but we still encourage you to use a HIPAA compliant platform just pragmatically, and we still have an ethical duty to maintain confidentiality. The kind of second, also very similar issue is that one has to carefully structure the context of the supervision. Where's the supervisee going to be? The supervisor. Is the setting quiet, private? Is the student, a practicum or trainee student, going to be interrupted? And then having a clear agreement as to the nature of the supervision. Some of you who've taken our supervision course before, we did a part of our workshop, may know that we suggest a kind of a 2-level consent process. a consent process to patients about the fact that there's a person being supervised, but then an agreement with the supervisee. And we think those agreements should be modified to reflect the reality of remote supervision. Now, it is different in at least a couple of ways. That is, remote supervision from doing, for example, remote therapy. The first is kind of a pragmatic issue, and also it is surmountable. This is not an impossible thing, is how do you get your usual work samples? So if you were typically doing live supervision, you'll have to go through the steps of figuring out and making sure the platform allows you to be there as a live supervisor. If you were doing having somebody video record or audio record, you have to go through the steps of having secure, technologically appropriate methods where you can download those and also view them at the same time together. Okay, so it's just kind of a pragmatic component, but perhaps key here, and at the risk of sounding a bit redundant, it's going to be very important for you to be looking at state law, particularly the board in your state and whether they permit remote supervision. And this is where right now the states individually are completely in control of whether that happens. Many states have relaxed, of course, requirements for having somebody licensed in their jurisdiction. If there's going to be continuing care, I have to be licensed, for example, in a different jurisdiction, but many states have had that continuing relaxation ongoing, including New York and Connecticut and California. However, most of those states have not extended those exceptions to professionals in training. So this creates a little bit of a risky situation. If the student and supervisor are in state, it would be helpful to check with the board website. I just got a notice today, for example, in California, and I wish I could tell you all 51 jurisdictions, Liesl, but this is just one example, that they're extending for another, at least through September, the rule about allowing remote supervision in California for mental health professionals who are in training, which is really good to know. But that doesn't mean the same is going on in Arizona or Georgia or Texas, okay? The other piece too is, what if the student and the patient are here in your state, but the supervisor is out of state, right? That's a little bit more tricky too, because on the one hand, usually where the patient is located, which is called the forum rule, is where the services are being provided, at least from a legal fiction perspective. But again, I would want to get as best possible clear information from one's licensing board. And remember that there are some risks here, because the risks are to the licensee, that is me as the supervisor, if the board hasn't okayed this for promoting the unlicensed practice of psychology, for example, and in an inappropriate way or in an inappropriate jurisdiction. The other risk is that there could be a risk to the student's ability, if they're getting hours for their supervised experience, they could lose those, and they could also get on the board's radar and there could be a complaint. So it's very worthwhile to be careful about this. I want to also note, though, that a component of this, Liesl, is that there are also countervailing ethical considerations, not just risk considerations. For example, continuity of care with patients and patient welfare. So if I have a patient who's moved from my state to South Carolina, and let's say South Carolina has, and I'm a supervisee, and South Carolina has said, which they have, you have to be licensed. Well, there still may be a good ethical argument for continuing care during a transition period. It does heighten the risk a bit, but we have to balance what the needs of the patients are. I think there's a better argument with a transition period and then handing off the patient to a licensed person in that jurisdiction, or perhaps in the jurisdiction where the licensed professional is not the person who's unlicensed, versus the harder argument of, now I'm going to start with a new patient who is of my practicum student or my trainee in South Carolina, okay, for those of us who don't live in South Carolina. So there are some nuances here, and it's state specific.
Yeah, that's great, Dan. Julie, anything you want to add?
The only thing I would add, I mean, I think the state specific piece is just vitally important, and you want to look at nuances because some states have a requirement, for example, that the supervisor be in this building or, you know, available in some way. And so you want to see how those might have been tweaked in order to allow teletherapy or telesupervision, I'm sorry. And I do think most state boards, the websites have some sort of COVID resources section at this point, and some of them have done a pretty good job of collating those into one place. So just be really sure that you're clear on what's in place, what's different right now, and do your best to comply with that. But otherwise, I think Dan covered a lot of ground with that answer.
I think you both did. One piece that I would just add, Dan, to what you said about that transition period, definitely, you know, there's that clinical and ethical argument, rationale. And then I think, you know, the question becomes, how do we define that transition period, right? I've been getting a lot of calls where people are like, I've been doing this for 3 months. Is that, do I have, you know, and especially when the clients are students and they may not be coming back to school this fall. So, you know, as with much of what we're saying today, I think there's no one right answer and there's no blanket amount of time for that, case by case, and consult. Dan, do you have any additional thoughts on that?
Yeah, just one other thing, and actually, Julie, your thoughts triggered these, and that is that, you know, like any remote service, whether it's in jurisdiction or outside, it's really going to be important for the supervisor to know where the patients are, and also for the supervisee and supervisor to know the local crisis resources. So whether the supervisee is out of state or the supervisor and the board allows it, you know, it's that practical kind of, we got to make sure that we're prepared in case there's an emergency with this particular client, whether for a transition period or just a vacation, you know.
Right, and in some ways, this is a great opportunity for us to sort of model that with our trainees, right? If we're always asking, we got to find out where the client is, you know, those kinds of things. That's great. Okay, so we are now going to jump into some of your questions. Thanks for all of you who've been writing in. The first one we'll take is, if this is about patients, if they are in a secure location, such as a hotel room or a friend's room, can I, the therapist, provide telepsychology services to a client who is traveling out of my state of jurisdiction? And Dan, do you want to jump in on that? Or?
I'll jump in on that. I think Dan took the last one, so we'll keep it even here. Yeah, I mean, I like the fact that this question started with if they're in a secure location, so that's good. But yeah, this is the interjurisdictional question, and if someone is traveling temporarily, and this was true pre-COVID as well, many states, most states have some sort of exemption for licensure that allows temporary practice into that state. And so a lot of those have been loosened significantly now for the current crisis, but those things were in place even before this happened. So what you would want to know is where the client is going to go, and try to do your due diligence and find out. If you're a trust insured, you can certainly call us and we can look up the relevant statutes in that state and see if there's a provision that would allow you to legally provide those services under a temporary practice provision. Like I said, at this point, with the waivers in place, I think most states have something going on, but it behooves you to check beforehand. That said, the legal consideration is not the only consideration, and Dan already alluded to this, right? We always look at legal, ethical, and clinical considerations. And if we're talking about a client who is a current client who's going on vacation for 2 weeks and who wants to have 1 or 2 remote sessions, and you believe it's clinically appropriate and necessary for them to have weekly sessions, then from an ethical standpoint and a clinical standpoint, it makes a lot of sense to provide those sessions, even if you're not able to, for example, comply with a requirement to apply for a temporary permit in the state where the person's going to be. It may just, you may not have time, and it may be too onerous for you to do that. And what you want to do in those situations is document carefully that you understand that there may be interjurisdictional issues and that you believe the importance of continuity of care and not abandoning your clients may override those considerations, that this is only a temporary situation. Now, I wouldn't try that if someone were going away for 6 months. I think, you know, the longer period of time we're looking at, the higher the risk is in a state where they don't have an exemption to practice like that. In Colorado, where I am, you can practice for up to 20 days into Colorado. And you don't have to do anything. There's no temporary permit, there's no fee, there's no notification of the board. So that's pretty flexible, but other states are very different. You have to apply for a permit. You have to sometimes have a sponsoring psychologist in the state, notify the board of the exact dates of service. So if you run up against a regulatory regime that's overly restrictive, and we're talking about a temporary amount of time, then we do think that you can go ahead and document those reasons and document those rationales, obviously making sure that the person is appropriate for this and always doing the things that we know to do in terms of what Dan just talked about. Where is the person going to be? What are the crisis resources there? What can we do if we do need to sort of get things going and help deal with an emergency situation? But I think the risk is relatively low when it's clinically appropriate, when it's temporary, and when the person can be in a safe and secure location and everybody is on board feeling like this is an appropriate mode of therapy for the client.
I agree. Great answer. Dan, anything to add?
No, Julie, I think you covered what I think is you've hit the notes here that I would sound. Yeah.
Yeah, I agree. All right, so we will move on. And this is interesting because I've heard more of these kind of questions too. How should we deal with colleagues who are caught up with quote unquote conspiracy theories and are not taking the virus seriously, especially if they work in the same building as I do?
Yeah, so, obviously if there are striking differences of opinion like this, it seems to me that one of the ways of approaching this is to say, this is what I believe, this is what you believe. We have different beliefs here, but our job is to protect the welfare of patients. And since the data seem to suggest, whether one believes them or not, that there's risk here, these are the steps that I think are necessary. And Lisa, if the caller is the person who holds the lease or owns the building, you can basically say, it's my way or the highway. But if it's a group of you and you all hold it together, then I think it's really important to meet together and sort out the differences beforehand and come to some basic agreements as regards what will the safety protocols be. Sometimes, I've been hearing this question, like I think both of you have, across the country, with some differences of opinion between clinicians about what steps should be taken. And at least on a couple of occasions, there weren't really any options but for the clinician to leave or to stay doing telehealth during this period because they just weren't comfortable with the other clinicians coming in and saying, I'm not doing anything and it doesn't matter what you tell me. On the other hand, there may be, and this is something where you might need to get local council input, you may, with your colleagues, be able to say, look, this is the rule that I'm abiding by, or these are the set of guidelines by CDC. If you don't abide by these, you are assuming the risk. Mm-hmm. Now, I'm not comfortable with that with patients because it's overreaching potentially with patients. But with a colleague, and we're on equal footing, then we can say, this is what we're doing. Where that falls short of being a good solution, and then I'll let Julie, respond at this point, Lisa, but is that if someone else doesn't wear a mask, the people at risk are the other people, not the person who fails to wear the mask. So it's hard to say that person's assuming the risk when they're putting the other people in the environment at risk.
Yeah. Yeah, this is a really difficult question, and it is coming up a good bit. And I think, this is stating the obvious, but the first thing to look at is what are the requirements where you are, because it may be surprising to some places are requiring masks indoors for healthcare settings, and they may not have that kind of a mandate in general, but it is something that's required. So make sure that you know what those requirements are. And obviously, at a minimum, everyone needs to be following those. And that to me is really a floor. I think most of us can do better than, well, it depends on what state you're in, but I think most of us can do better than the minimum. And it is a matter of just trying to outline, here's the risk and here's who you are putting at risk. And I agree with Dan completely. The dynamic there with a colleague is completely different than that with a patient. And I think that you can be a little more forceful and you can say, look, you're putting everybody at risk by doing this. And, you can come up with a little more forceful solution or extricate yourself from the situation and decide not to engage. But it's difficult. We are in such a challenging time. It's lasted for such a long time, and there are so many other stressors going on right now that these things that seem like they shouldn't become big issues have become big issues. So we all need to kind of take a collective breath as well and just think, what is ethically best for our patients? We are charged with avoiding harm to patients. And that would be a big argument for me and any clinician who wasn't willing to take all the necessary protocols.
Yeah, I agree. Good point, Julian. I would add to when you were talking about the safety precautions and stuff. I mean, I think one of the things that makes it additionally complex is that they're changing so often, states and country. And so, it is important to keep aware and keep abreast of what is happening in your locale, right? And what are the mandates? What are the requirements? What are the suggestions? And you may also want to let your clients know that may change, right, over time. So again, it's not a one answer for one specific time. Okay, so we're going to turn now to a HIPAA question. It says, I have been consistently told by legal counsel that electronic transmission of PHI makes a practice a HIPAA-covered entity. We have had this in the past. Now, during the pandemic, we are using a HIPAA-secure payment app called Ivy Pay. I don't think that matters, but we will not use this app after the pandemic, and we are back in person. Is using a HIPAA-secure payment app considered electronic transmission of PHI, and are we now a HIPAA-covered entity? Julie, I think you're up for this one.
That's a really good question, and it's a tough one. I mean, as a risk management consultant, I'm going to take the conservative approach and say that if you're using electronic means to transmit information, you might want to consider yourself a covered entity and follow those protocols. There's not really that much that HIPAA asks of us. I mean, there are some things that they ask of us, but generally that HIPAA standards for privacy and security tend to be fairly standard for practice for psychologists, right? We are supposed to take reasonable measures to protect information, regardless of whether it's electronic or physical. I do believe that the actual trigger is to be transmitting information for claims purposes. So I am not completely sure that Ivy Pay would meet that standard. But you do, I think that it behooves us all to be as conservative as we can when we're dealing with electronic transmission of information. And even if you may not be a HIPAA covered entity, it still tends to be a good idea to use HIPAA compliant platforms because they do have that level of security. But I don't think, and I think Dan was holding his finger up to talk about the transmission for claims purposes. So I think that is hitting the nail on the head right there. So the answer may be, you're not technically a covered entity just by virtue of using Ivy Pay, but to still engage in secure practices regardless. And when we're using technology, HIPAA compliant platforms that can be used in a HIPAA compliant way are the safest way to go always, whether or not you're a covered entity.
Yeah. I agree, Jill. I was giving you my thumbs up on that, what you were saying about this, because that question has come up a few times. If I sign a business associates agreement, whether it's with Ivy Pay or whatever the platform is, am I now a covered entity if I wasn't before? And that's not what triggers HIPAA. What triggers HIPAA are a series of what are called covered transactions. And those typically, although not completely, but typically have to do with transactions that are financial in nature over the internet. Okay, but again, it's very detailed. It's complex complex regulation. But the use of something that is HIPAA compliant doesn't then require you to be HIPAA compliant. But as you're saying, Julie, is it a really smart idea? Yeah. For practical risk management purposes. Also, although I don't think it's happened yet, it may be the case that over the next years we're going to see kind of the HIPAA standards looking more and more like community standards of care. And I would have to be able to make a very cogent argument about why I wasn't using something that was secure enough according to HIPAA, even if I'm not a covered entity. But that hasn't happened yet, to my knowledge. And Ivy Pay or whatever the process or the organization may be, simply by using them for billing doesn't necessarily, or to do transactions, doesn't necessarily mean that you are using a covered transaction, which is kind of interesting. It's a different kind of definition.
Right, and those are good points. And this is slightly tangential and may not be what the author of that question had meant, but I think it's also important to remember that, right, HIPAA, once it's triggered, you're forever a covered entity, right? If you were a covered entity in the past, even if you're no longer transmitting PHI, you still are a covered entity, right? I mean, Dan and Julie.
Yeah, you got it.
It is that way forever. So that's just important to keep in mind too. Okay, this is a fairly easy one, but we'll do it just because I think multiple people have been asking it, so it's good to get the information out. Does the trust malpractice policy cover providers who have limited visitors license in other states other than the state of their primary license?
Yeah, so if you're practicing legally in another state, whether it's temporary and like Arizona or Colorado allows 20 days, then your coverage follows you. And so the issue is, are you within the scope of your licensure? And if you're working temporarily and you're within the scope of your licensure, I'm pretty confident saying, even though we normally get asked as risk managers, as you both know, not to interpret the contract, but that's a pretty fundamental standard around remote and interjurisdictional practice.
Yeah, great. Okay, so, and here's a couple questions on returning to in-person, which I know we've been getting a lot of, and it's very complex. So, are the recommended measures, are the measures recommended for reopening for in-person appointments, quote unquote, scalable for settings such as one-person offices in areas where the infection rates might be very low? Julie, you want to start with that?
Yeah, I think that's a great question, and I definitely think it matters. Your location matters a lot. The risk factors and the exposure level of your location is going to matter. And you know, I don't know that it's scalable in exactly the same way that HIPAA is, but certainly you're not going to be required to, you know, if you have a small solo practice and you rent an office 2 days a week, you don't have control over the HVAC system, so you're not going to be the one who's expected to make those changes. So you try to affect the change you can, but you're not going to be expected to have the same kind of standard as a large hospital system or something along those lines. Really the important thing, and I know we've said this several times and we may say it a few more times, is to know what is required where you're located. And that is what you need to be following. And so it really doesn't matter if, you know, if you're in an area with a low level of infection, but your state has a statewide mandate for certain protocols, you need to follow those protocols, even if they seem like overkill, because it's your mandate. And if you're not doing that, you could be deemed to be negligent in how you're reopening. So you really do need to make sure that you do everything that's required. And again, that's your minimum. But, you know, are you going to buy a several $1,000, you know, ultraviolet air filter type thing for your practice when you see 2 patients a week and you can open your windows? You know, it is very, very context specific, and it is very, I mean, there's no one answer for anyone, because all of our circumstances are so different in terms of the kind of work we're doing and the patient population we have. If you're working with a geriatric population or a child population, all of these, they're wildly different, and there's lots of really different considerations. So it's so tricky, because we tried to put out some guidance and we put out the informed consent sample, but even those are just bare bones, and it really needs to be filled in based on what your practice is like, where you are located, what the population is, and what you're able to do. Again, if you have windows that you can open, great. If you're in an enclosed office and there's nothing, you have no ability to control the air HVAC system, might you put a small air filter in there? Yes. How effective is that? We don't know. And so make sure you're aware and staying on top of what your public health orders are in your county and in your state, and make sure that you're following those mandates. And then for a lot of people, that doesn't feel enough. They feel like their risk level or their client's risk level is more. And so they feel like they need to put a few more protocols in place. So there's no blanket answer. It's really good. I don't know about you, Liesl and Dan, but I'm intimately familiar with the public health page in my state now, and I'm checking it every day, and there's new executive orders and public health orders, and the end of each month I go refresh all of that, because a lot of these things are 30 days at a time. So it's extra work, but it's really important extra work right now to just try to have some kind of mechanism for staying on top of those things.
Yeah.
I agree. Dan, any addition?
Yeah, just to kind of highlight one thing, Julie, you said, which is that this, I think that it's not scalable in the way that HIPAA is. It is definitely, we can adapt, but if you, for example, have patients who are older folks and you're working with a lot of folks on Medicare, just age-related risks go way up. And so will it be enough to say, well, my office is small and I'm just doing 2 days a week, but I'm going to see all of my patients in person. Arguably, that's not going to fly, particularly if the state is setting minimum standards and requirements for offices like New York State is. You know? So it's going to be a case-by-case determination and a practice-by-practice determination, as Julie, you were saying. But I think it's very important to look at one's own patients, their risk level, their family members' risk level, the clinicians and our family members' risk level is relevant, as well as where the needle has moved in a particular jurisdiction. We're seeing some jurisdictions now that are walking back from phase 3. And they're doing that because there have been spikes. And, you know, there were literally, I guess it was today or yesterday, DeKalb County in Georgia sent out, you know, what folks thought was an Amber Alert, but it was an alert that there was a spike. And so that is going to, we're going to have to be flexible enough to adapt to very rapidly changing circumstances.
Yeah, I agree. Those are all good points, Dan. And I would just say, I know we've said this before, so it can sound redundant, but I think even in this case, it's important to whatever you're choosing to do, and importantly, what you're choosing not to do, to really document your rationale for that. And I think it's also really important that if there's something in particular that you are choosing not to do for some reason, you should let your clients know that, so that the decision whether or not to come in can be fully informed, right? Because they need to be about this too. So lots to keep in mind. And again, you can call us, right? I mean, you know, if you want to talk about your particular situation, feel free to give us a call and we'll talk that through with you. One more question on this here, that I think some of the complexities you were mentioning, Dan, but I'll ask it because I know it's been raised by a lot of folks, is it's a little bit long, but when we are considering seeing one or more clients in person, because there's a sound clinical reason to do so, but one of those clients or one of their close contacts has health vulnerabilities, what do you recommend we consider in order to help determine whether the clinical reason for in-person outweighs the risk of the health vulnerability? And they say for this question, assume we are doing things like disinfecting, masking, etc. And should they request something verbally or in writing from the client or their close contacts from like a medical doctor stating that in-person psychotherapy is safe or not contraindicated, or are there other ideas?
Yeah, so a couple of things. One is actually, I think it's not a bad idea at all to have a primary care physician weigh in about where there's a patient or client who has a compromise, and combining that with something Julie referred to already, which is that having a individualized analysis. You know, I don't think, you know, in a hypothetical, there's no way to know without specific facts, how are we going to weigh whether somebody's risk factors physically outweigh their psychological risk factors? If you're concerned about significant decompensation of a patient who is becoming more and more suicidal than a person with some minor pulmonary compromise, you could make a much better argument that they should be seen in person if they're not responding to remote services. On the other hand, if they're relatively stable and they've got that pulmonary compromise and there isn't that kind of press clinically, they just want to come in, I think it's a harder argument to make. And so it's going to be a particularized analysis that gets documented, Liesl, in one's record. And I think, you know, consulting about those circumstances, checking with healthcare providers, primary healthcare providers, having them write something that says, yes, you know, this is low enough risk for this person, or these are the extra steps that may be necessary. So we may take all of the basics that are required in our jurisdiction, but, you know, primary care doc may say, well, this person's going to need more. They've got to have an N95 mask or they shouldn't go in your office.
Yep, I love that idea of involving the primary care physician, because this particular question is a medical question, and we can do our best to use our judgment and figure out what might work, but there's nothing that's going to substitute for the actual physician being able to chime in and say, here's what really needs to happen, and if you can't do those things, then it's contraindicated.
Great. I'm going to try to fit in just a couple more in the very few minutes we have. And this is specific to college counseling centers that we're getting more and more calls on, I think, because fall semester is coming. And they say, are there efforts in play to give exceptions to counseling center psychologists to serve students enrolled in a college in their jurisdiction, but where the student is required to relocate in another state? So Julie, why don't we start with you?
Yeah, I don't know if there are such efforts in place, but it sure does make a lot of sense, doesn't it? And it would be the kind of thing that if it's not happening, this is where state associations and advocacy on the state level is really important. And this is where if you have concerns about this, and the time is now. It's already July. I don't know how on earth that happened. This year has been both the longest one ever and has gone by faster than I can even conceive of. But we're getting close to having to make these decisions, and now would be the time to start looking for some way to advocate for some flexibility there, because it's tough. It's one thing to say interjurisdictional practice is okay if it's on a temporary basis. But if we don't know what temporary is going to mean, if we thought it was going to be for this month or for these 2 months or for the summer, and now it's continuing to extend on, it really is hard to know what the right decision is clinically. Do we go ahead and bite the bullet and terminate and refer, with the potential that what if school opens back up, and we've made that move and now they're going to come back to us. So I think that it's something I don't know, and I'd be curious to know if either of you know of any efforts currently underway like that. But if not, it's definitely, this is exactly the kind of thing that advocacy at the state level can be incredibly effective in moving things forward. So I'm curious to hear if you all know of any such efforts. If not, you don't necessarily have to be a member of your state association to start things moving, right? You can reach out to the state association anyway and say, I'm interested in this topic. What are you guys doing about it? And if they're not moving in that direction, that may provide the momentum for them to start making some moves there.
Yeah. And any addition?
No, I think, Julie, you got it.
All right, so we're going to squeeze in one last one. Real quick.
Talk fast.
Is there legal liability if one of your patients whom you saw face-to-face develops COVID? Assuming you both wore masks, observed social distancing, etc., could they come back after you stating that somehow you harmed them? And Dan, you want to take that real quick?
Sure. They could try, but this is going to be one of the hardest lawsuits to bring successfully, because if they've been in your office, they've been somewhere else. And how do they prove the causation link? And so that's going to be tough. But having said that, Liesl, I do think there is some elevated risk. It's not huge, and I don't want to overblow this by any means. But if we don't use masks, if we don't engage in the CDC or state recommended levels of protection, then I think there's a licensing board complaint that could have more traction, because it could show that we didn't do the steps that have been recommended. But in terms of a malpractice and negligence liability, that's a tough case. I think it's, while we may see suits like that, the likelihood of their being successful, very low.
Yeah, I agree. And I think that's where I think both of you, Dan and Julie, you've mentioned that we need to be in compliance with whatever the state recommendations are. And that is actually how we protect ourselves from that potential licensing board complaint.
And just to end, because I know we have to stop, but if there is a malpractice suit, then having complied with CDC and state requirements also is protective.